Hi, welcome to Cases from the Coop. My name is Sandhya, and I'm a PGY1 at Cooper, and I'm going to take you through one of my very first cases I had as an intern. So I had a 43-year-old woman who came in with a complaint of shoulder pain. Her pain was a 10 out of 10, and she was crying in triage. When I saw this patient, she was sitting in a wheelchair, and she looked very uncomfortable. She told me that right before she came to the hospital, she was cleaning her house and slipped on some juice, hit her right shoulder on the couch. Her right shoulder looked extremely abnormal. It was internally rotated and abducted, and the shoulder looked very squared or flattened. One of the first things I did was to make sure she had sensation over her deltoid muscle. I checked her radial pulses, and then I made sure she made an OK sign to assess her radial nerve. So this is what her shoulder looked like. As you can see, her acromion is very prominent. So just to help you out with some of the anatomy, some of the bones that make up the glenohumeral joint are the humerus and the scapula. And as you can see, the humerus articulates with the glenoid right here. So this is going to come in handy when we look at our ultrasound. One of the first things we did was to get an x-ray. In general, it's important to have multiple views of the shoulder. As you can see on the right, the shoulder looks like it's not in place. In other words, the head of the humerus is not articulating with the glenoid. When using the ultrasound, it's important to try to get an image that looks like this. Position the patient upward and sitting upright. Use a curvilinear probe and place it on the posterior aspect of the patient's affected shoulder. Make sure the probe mark is lateral and in the horizontal orientation. This is what a normal shoulder looks like. As you can see, the humeral head is farther away from the probe than the infraspinatus muscle and the deltoid. In other words, when someone has an anterior shoulder dislocation, you can see that the head of the humerus is farther away from the probe. In other words, it's more anterior. You can see the glenoid right here and the humeral head right here. This is what my patient's shoulder looked like after it was dislocated. As you can see, once again, using this dynamic view of the ultrasound, the head of the humerus is not where it's supposed to be. If she had a posterior shoulder dislocation, the humeral head would be closer to the probe. So this is what my patient's shoulder looked like when she had her dislocation. As you can see, this is the head of her humerus, and it's not articulating with the glenoid, which is right here. If she had a posterior shoulder dislocation, it would be closer to the probe, right around here. So how we helped her pain was we injected about 15 cc's of 1% lidocaine into the shoulder joint. As you can see, there's a needle right here going into the joint space. My patient experienced a lot of pain relief right after we did this. So this is what my patient's shoulder looked like after we reduced her shoulder dislocation. The reason we decided to use ultrasound is because intra-articular lidocaine is a lot faster, requires less resources, less nursing than conscious sedation. In this case, a patient really wanted to try this, and she experienced almost immediate pain relief once we were able to put all of the lidocaine in the joint space. The reason we like ultrasound is because you can watch the needle going into the joint space, and it's more accurate than estimating via landmarks.